Okay, so we're going to talk about the urinary system today. There's a lot to it. I'm not going to cover in depth and any of it. You're responsible for all of it. So we'll go ahead and we're going to review just real quick what the urinary system consists of. So there's 2 kidneys, 2 ureters, 1 bladder, a urethra, and they're bean-shaped. They measure approximately 4.5 inches long, 2 to 3 inches wide, and 1/4 inch thick. The left kidney is slightly longer and narrower. And here is a CT. You can see left kidney, right kidney, gallbladder, and you can see coming out is their urethra. So they lie in an oblique plane about 30 degrees toward the aorta. They extend from T12 to L3, and the right kidney is slightly lower than the left. There's a capsule, cortex, medulla, there's columns, and there's nephrons. You should know what each one of these are and what they do. I'm not going to go through it because you should already know all of this. So, important thing here, glomerulus is a filter for the blood. So, and it allows fine particles of water to pass into the capsule. So, really important that you know what that is and what it does. So there's, let's see, calyces, there's collecting ducts, there's minor and major calyces, so make sure that you know the difference between the two. There's the hilum, the renal pelvis. Know what each one is as far as the anatomy and what they do. The ureters are 10 to 12 inches long. They go from the kidney to the bladder. And the urinary bladder is a muscle, and it's a sac that holds the urine, so it's a reservoir. And it's located superior to the pubic symphysis on almost everyone. Sometimes we have renal prolapse where it falls and is below the pubic symphysis, so you have to be aware of that. Let's see, the neck is the lowest part. There's the trigon. It's a triangular area on the bladder base. It's between 3 openings, so where the 2 ureters come in and the urethra heads out. So you can see here the trigon. You have your ureters coming in and your urethra going out. Here is a CT with contrast, and you see how small the ureters are. Here's the urinary bladder. So, urethra, what it does, so it brings the urine outside the body from the bladder. So you have the kidneys and you have the ureters that bring the urine from the kidneys to the bladder, and then you have the bladder, and then the urethra brings the urine out of the body from the bladder. So it's about 1/2 inch long in females, 7 to 8 inches long in males. And the men have prostates, not the women. And it's considered part of the reproductive system, but we look at it also during the urinary system. And it measures approximately 1.5 inches transversely and 3/4 of an inch at its base and 1 inch vertically. So that gives you an idea if it's enlarged. That's the normal size of a walnut, they say. All right, we use contrast studies to look at the renal parenchyma, and we need that to see the actual whole urinary system. We can do it antegrade or retrograde. So here, lower concentrations are required for the bladder because such a large amount fills the bladder, and if it's too dense, we can't see through it and see if there's any polyps or tumors. So we use high concentration for any kind of excretory urography. So we use non-ionic when possible, and pretty much everyone uses non-ionic now. So, prep. To see the urinary system well, we need patients to do clean out their system, a bowel prep. We don't do it on infants or kids, only on adults, and it depends. If it's something that we don't need to see fine detail, then it's okay that they didn't prep, but we usually like them to prep for this so that there's not fecal matter or a lot of gas in the area where we're looking. So, low residue diet for 1 to 2 days, light evening meal. usually the day before, and then non-gas forming laxatives, and nothing to eat after midnight before the exam. And patients should be well hydrated. That's something that's really important. So hydration, particularly important on patients with diabetes, multiple myeloma, and high uric acid levels. These put these patients at risk for contrast medium induced renal failure and dehydration. So really important that they stay hydrated before the exam. For retrograde, patients should drink 4 to 5 cups of water several hours before. No other prep is required. The equipment you can use is a standard x-ray room for any kind of IVPs or IVUs, and if we're going to be using retrograde contrast, we usually use a special table for that. Unless it's a kid, we can use our normal table. So combination of cystoscope, radiographic unit needed for retrograde, like I said, and there's also a tomo unit that we can use for doing tomograms of the kidneys. So the equipment, so time interval and body position markers should be used. So when you're doing a 10-minute, you should have a 10-minute marker, just so you know that it's normal to use these markers. Let's see. You should have your crash cart available and all your venipuncture supplies. So for the procedure, we're looking for image quality. We need to control the motion. We sometimes do compression, and I'll show you what that is. We need to be concerned about respiration to keep the kidneys in the same spot each time, and radiation protection, of course, when we can. So contrast and density is the same for all the images, so you need to make sure that you manual technique. You can phototime your first one, but then manual technique it from there on out. So the soft tissues that must be defined is the kidneys, the lower border of the liver, and the psoas muscles. And we want bone detail varies with the thickness of the abdomen. So if they're thinner, we can see it. Sometimes if they're really large, we don't. Motion control, we don't normally use immobilization because it interferes with the flow of urine down to the bladder. Motion control, so we want real fast exposure time, and you need to make sure your patient's cooperating. And it's important to talk to the patient about how they're going to feel with that contrast injection. So compression. When we do an IVU or an IVP, sometimes we put compression over the distal ends of the ureters. The purpose is to stop the flow of urine to the bladder and to really see the renal pelvises and calyces. So we put the compression, they're little squares that blow up as balloons, and we center them over the ASIS. So we apply and remove slowly to reduce patient discomfort. And the contraindications that we now ever use compression is for stones, abdominal mass, aortic aneurysm, colostomy, suprapubic catheter, or traumatic injury that we can cause more damage. So this is how it works. Sometimes we just wrap this unit here around the patient. It has Velcro and connects. We use a hard board typically underneath the strap. And then we have those squares, and I'll show you. You can see the squares here. So these squares blow up into balloons. So they're flat, and then we blow up balloons. And it's got this on there to keep it from expanding, so it goes into the abdomen and stops the flow of urine. So you can see there's no urine going past that, so we can see the pelvises and calyces really well on a patient for a IVP. So when you release it, you got to release it slow, and typically when we release it, we're all completely set up to do a full KUB, so we can see the ureters all the way down. So you're going to release and shoot immediately. Okay, so respiration. All exposures should be made at the end of expiration, and you want it the same each time. And we do it expiration so that the ureters are completely expanded and not coiled up. So if you do it on inspiration, it's going to push the kidneys down, which is going to kind of coil up and make the ureters redundant. So we want to do it on expiration and do it the same each time. Also, we use the the markers. So the markers should be put on the film. So you're doing an immediate, a 3-minute, a 5-minute, a 10-minute, a 15-minute. So each one of those needs to be marked. All right. Typically we do a KUB before we start to make sure that it's safe to proceed. We show that to the radiologist prior to starting the exam. And let's see, we check to make sure that they're prepped also, and it's good for our exposure factors. So I usually manual technique these after I get my first reading. So I'll look at my first read, so it reads out 75 at 25, and I'll manual technique from there on out because I don't want any kind of sway in my exposure factors. You want them to be the same all the way through. So protection, so you want to make sure that you protect where you can. When we're doing just kidney shots, you should have full shield on the bottom half of the patient. For male, you can shield throughout the whole thing. Females only when it's just of the kidneys. All right. Make sure you rule out pregnancy prior to doing the exam. There's a lot of radiation to that area. All right, let's get into the procedures. So there's intravenous urography, and it's an IVU. We also call it intravenous pylography, so IVP. There's nephrotomograms, nephrorurography, retrograde urography, cystography, cystourethrography, and we do those on males and females a little bit different. So intravenous urography, so IVU or IVP, demonstrates structure and function of the kidneys. It evaluates abdominal indications, so evaluation of abdominal masses, cysts, and tumors. We look for stones, we look for pyelonephritis, hydronephrosis, trauma, so a lot of ruptured bladders or injured kidneys. Preoperative evaluation for function, size, and shape, and renal hypertension. Contraindications, so related to the patient's kidney function, basically is the ability of the kidneys to filter out the contrast, and if there's any allergies. We use non-ionic, which helps a lot, and we also can do these studies in CT or in ultrasound, so it's safer for the patient. And that's pretty much where it's gone, so you're not seeing a lot of these studies anymore. The risk factors, asthma, previous contrast reaction, cardiovascular disease, elevated creatinine levels, sickle cell, diabetes, multiple myeloma, all of those, you need to sit up and pay attention and talk to your radiologist before you inject the patient. Before the procedure, patient must empty bladder. Really, really important. You need to get the patient changed into a gown. You need to review their kidney function and run an eGFR, not just a GFR, an eGFR. And you need to make a scout radiograph. So as you can see here, the dotted lines are the kidney. You have here is the psoas muscle, and then the lower border of your liver. So you're going to do venipuncture. You're administered, depending on the patient's size, 30 to 100 mLs of contrast, and it changes, it's weight-based for kids. And you're going to take radiographs at specific time intervals. Most common radiographs for IVU are AP at the time intervals ranging from 3 to 20 minutes, and the radiologist will have a protocol, and you need to look it up and you need to follow it. So AP oblique projections, we do a 30-degree posterior obliques. We usually take them around 5 to 10 minute intervals. So usually we'll do an immediate, a 3-minute, a 5-minute, and then we'll do both obliques. So each protocol is different. So once you're done with the exam, you're going to send the patient to the restroom, and then you're going to have them come back and you're going to do a post-void of the bladder. Typically we do these upright to check for prolapse and residual urine that's left within the bladder, and which could cause frequent UTIs. So here is a post-void. Normally we have wait, I lied. This is a 3-minute. I'm all, wait a minute. So 3-minute, you can see contrast just starting to head into the urinary system. It's just starting to fill the bladder. None of these are marked, of course, which is awesome. So normally you have a 3-minute, you'd have a 5-minute on here. So 5-minute, you can see more in the bladder. As you can see, we don't see the ureters coming down well. The kidneys have blushing. We can see the blushing of the kidneys and some contrast being filtered out. Here is they have a 9-minute. Each protocol is different, so you can see that there are some markers on here that they've clipped off. So 9-minute, you can see more contrast in the pelvis, coming down the ureters and filling the bladder. Okay, AP urinary system. So you're in position, patient supine, support the knees so that the back is not strained and the kidneys are closest to the table. We can do upright position to demonstrate bladder and kidney mobility. So sometimes when you stand them up, the kidneys drop down into the pelvises, which is really interesting. So you want for AP urinary, MSP aligned to midline. You move the arms out of the way, center IR to the level of the iliac crest, just like on a KUB. 2 IRs may be used to demonstrate on tall patients. Most of the time you can just do a T-top, so lengthwise 14 by 17 with a crosswise one going across the kidneys. That works also. I typically like T-tops better. So everyone's pelvis will fit on a 14 by 17 lengthwise. It's just if they're really large, you'll want to do one across the top to make sure you get the kidneys. All right, you're going to do that for all your views. So whatever you do in your scout, you're going to do for all your views. You are going to have your CR perpendicular at the level of the iliac crest. And this is what we're looking at here. We have your renal calyces with your renal pelvis. You have your ureter coming down. You have a pelvic ureter down here, and here's your urinary bladder. So obliques, you're going to be supine, and you're going to have the kidney closer to the IR will be perpendicular to the plane of the IR, whereas the one further from the IR will be parallel with the IR. So you're going to rotate so that the mid-coronal plane forms a 30-degree angle from the IR. The shoulders and hips should be in the same plane. MSP aligned to the midline of the grid and move arms out of the way. Nothing worse than getting an elbow in your kidney. Center IR to the level of iliac crest. Your CR is perpendicular to the center of IR. Enters approximately 2 inches lateral to the midline on the elevated side of at the level of the iliac crest. So here. So you're going to be more on, you're going to cheat and go 2 inches from midline on the upside. And you're going to go to the crest. So as you can see here, we've got great shot of the kidney. We've got the ureter going all the way down. If you go steeper, it's going to put the ureters into the spine. So you got to be real careful, real shallow, 30 degrees. So looking here is an RPO at 10 minutes. Lateral. So you can have the patient in lateral recumbent or on right or left side, knees flexed, MCP centered, elbows and arms overhead or in front. It doesn't matter. Center IR to level iliac crest. You're going to have the CR perpendicular entering the MCP at the levels of the iliac crest. So right here. So this guy's crest seems a little high in this picture. I would assume the crest is here. So you see how much higher he is. So I'm not sure what's going on. And here is the middle of the cassette, so I'm not quite sure. So if you're centered at the iliac crest, this is incorrect because that's it right there. It seems a little like the patient wasn't centered properly. So you want to make sure you're at the iliac crest. All right, so dorsal decubitus, so supine, right or left side in contact with the gridded device, arms above head or across chest. Adjust the height of the vertical grid so the device, so the long axis, and you're centered at the MCP, and you're going to center it to the iliac crest. CR is perpendicular, enters at the MCP at the level of the iliac crest, and this is what it looks like right here. Really easy to do. You can just use a gridded cassette to shoot this, and once again it seems a little high. His crest seems a little high, and sure enough, here's middle. So I'm not sure why they keep positioning incorrectly. All right, tomograms. So tomography performed immediately after contrast injection. I usually do an immediate and then I go straight into my tomos. It demonstrates renal parenchyma and the collecting tubes. It's good for hypertension, cysts, and tumors. And this is what it looks like. So you're going to use a 10 by 12. Here's your kidney and your major calyces, your pelvis, and ureter coming out. So what it's going to do is it's going to take a 1 centimeter slice of the kidneys and blur everything else out. And you're going to set the level. So you can say I want 8 through 12. So it's going to do an 8, a 9, a 10, 11, and 12. So you're going to do 5 images. And it's going to just take each level so you get all the way through the kidney doing this. So it shows it really well. And here, there's 2 projections. I'm only showing you one just to give you an idea. So this one, A is at a 9 centimeter. So you can see we're really well into the kidney on a 9. It's perfect of the pelvis, but on the left kidney, we're not in the kidney. We're not midline. So they don't sit the same inside the body. So a lot of the times you're doing 4 or 5 images to get through the kidneys so you can see all of them well. See both of them well, not all of them. Okay, so here is just a KUB of the kidneys. So nephrotomograms and nephrorurography, so same indications, and retrograde urography. So it requires catheterization of the ureters. Contrast is injected directly into the pelvic system, provides improved ossification of the renal collecting system, and indication for evaluation of the collecting system in patients with renal insufficiency or contrast sensitivity. So we don't use as much contrast, and as you know, as we go up and to the kidneys and we inject contrast, the kidneys are filtering it out. So the patients who are real sensitive to contrast, this is a better way for them, but it is considered a procedure usually within the OR. All right, so here patients positioned on table for retrograde urography or modified lithotomy position. So here is the catheter within the bladder, and then you can see the catheters going up into the kidneys. And this is with the contrast, so you can see it's filled the kidneys and you can see the ureters coming down. So retrograde urography, classified as an operative procedure carried out under aseptic conditions. So you'll go up to the OR to do these, or the cysto room. There'll be a cysto room. I don't know if some of you guys have those. So the cystography is looking at the urinary bladder. It's usually performed retrograde. It's the easiest way. We do these on kids all the time. A lot of times we'll do avoiding cystourethrogram, but we'll do cystograms on adults with bladder cancer often. So it's good for reflux, recurring UTIs, neurogenic bladder, bladder trauma, lower urinary tract fistula, urethral structure, posterior urethral valves. It's good for seeing those. Contraindication relates to catheterization of the urethra. So as you can see here, we go in with a catheter and we fill the bladder. Patient is supine for axial position, MSP centered to midline, shoulders and hips in the same plane, arms moved out of anatomy, legs extended. CR is center IR 2 inches above upper border of pubic symphysis. So your IR is going to come in 2 inches superior to the upper border of the symphysis. All right, so for voiding studies, it's at the level of the symphysis for voiding studies. So for the axial, axial usually means that there's an angle. Bladder, angled 10 to 15 degrees, caudad to enter the IR, enters 2 inches above the upper border of the pubic symphysis, and the CR angle depends on how the spine is curved. So if it's you have lordosis, then it's big, then you're going to go smaller with your angle. You don't need to go as much. So here is your axial, axial image, and this is just showing you the catheterization. It looks like there's a bunch of air in that bladder. All right, AP or PA axial bladder. So you're going to lay the patient prone, MSP centered to midline, shoulders and hips are equal, arms out of interest, and the IR is centered to the CR, and the CR is angled 10 to 15 degrees cephalad. So when you're doing AP, it was caudad. So we flip the patient over, we flip our angle. So 10 to 15 degrees cephalad, enters 1 inch distal to the coccyx, exits just above the superior border of the pubic symphysis. So when we do the AP oblique, we're 40 to 60 degrees posterior oblique position. The right posterior oblique or left posterior oblique depends on the physician's preference. So usually we angle the patient which way so that they're facing us. So however they are on the table. So align the pubic arch closest to the midline of the IR, extend and abduct the thighs of the elevated side to prevent superimposition of the bladder. You're going to center the IR 2 inches above the upper border of the pubic symphysis and approximately 2 inches medial to the ASIS. And you're going to go to the level of the pubic symphysis for any kind of voiding study. So, and I'll show you pictures. So, your CR is perpendicular to the center of the IR. CR will fall 2 inches above the upper border of the pubic symphysis and 2 inches medial to the ASIS. If bladder, neck, and proximal urethra are of interest, 10 degrees caudal angle of the CR will project the pubic bones below. So that might be a test question. How do you angle the tube to project the pubic bones out of the bladder? So give you an idea. All right, so here you go. Center of the ASIS and 2 inches. Easy. So there is your bladder shot, and this is RPO. So lateral bladder, you can do it recumbent, right or left side, knees flex, MCP aligned to midline, flex elbows and arms out of the way, center IR 2 inches above the upper border of the pubic symphysis at the MCP, and you're going to be perpendicular to the IR with your CR, and it's going to enter the MCP at the level 2 inches above the upper border of the pubic symphysis. So there you go. And notice the shield behind to clean up the scatter. So there's your bladder right there. Good shot. Okay, male cystourethrography. May be performed via endoscope. So essential projection is AP oblique, so it demonstrates the bladder, neck, and urethra as little bony superimposition. So patient position, recumbent, 35 to 40 degrees, posterior oblique, IR centered to the superior border of the pubic symphysis, and you're going to elevate the pubis so it's centered to the midline. The image should demonstrate superimposition of the pubic and ischial rami of the side down and body of the elevated pubis anterior to the bladder, neck, urethra, and prostate. So here we go. So here's your bladder. Here's your prostatic urethra, and it comes into your spongy urethra. So the males have 3 different parts of the urethra. So basically what you want to do is you want to roll them up so just enough to where you can see the full urethra. So it might be a matter of making sure that it's not across the femur, that it's not coming just straight across here. You need to make sure that it comes out and you can see the full urethra while they're voiding. Females, as you can see, very small, very short, really easy to do compared to a male. So the thing is with the male, you can give him a urinal and have him pee into a urinal, whereas the female, it pretty much just makes a mess. So really short urethra though. Image critique. So I'm not going to go into too much detail. You have your image analysis book. I want you to do your image analysis book, and therefore you will have covered all of this really well. You need to make sure you have proper collimation on all your views. Don't clip your kidneys on your kidney shots. So here's all of your different things that you need to have on your film. So really important you use your time markers. I don't really like you guys to annotate that on. I want the actual marker on there. So it can't be changed and the doctor knows that's truly what you shot. Okay. So You have your bladder that you need to make sure that you have all the image critique down for the whole system. Okay, so that is your urinary system. I know it's a lot. We don't do them as often as we used to. We used to do, oh gosh, between 5 and 10 of these studies a day. So now we do maybe 1 or 2 a year. But it's important that you know what it is and you have an idea so that you can get everything set up properly and don't stand there frozen. Okay, good luck with all of your urography.